How long do you think it will take for you to make the transition from Northern Cal to Southern Cal?
We're looking tentatively right now about 4 to 6 months.
I'm assuming we'll hear some public comment about that. Any questions? Senator Stone.
Yeah, thank you for the presentation, and we definitely have a need out in Southern California, Los Angeles, Riverside County area, so we look forward to you working your way down. The Department of Health Services submitted a proposed waiver to the federal government for the substance abuse program, and one of my concerns is the waiver fails to give counties the ability to use FDA armamentarian drugs, if you will, to abate addiction. As an example, what's been approved for heroin or narcotic addiction is methadone and other narcotics, but Vivitrol or naltrexone, either injectable or oral, is a very important part of the treatment protocol, FDA approved, that, as you know, reverses the effects and doesn't allow one to have the effects of narcotics for those that have been addicted to it and want to derive a high, which is the motivating factor for their addiction to begin with. So will this new waiver in any way give counties the flexibility of utilizing the full FDA arsenal of medications used to abate these addictions? And if not, what is the rationale for denying the counties that option?
Sure. So part of there's lots of pieces to the waiver, and I could talk about it for days, and you can tell I'm getting really excited. But one primary focus is increasing medication-assisted treatment because it's an evidence-based practice. We believe fully that it is a way to decrease costs and assist the beneficiaries. And so one thing that we are doing in the waiver is allowing the use of buprenorphine and disulfiram in the NTP setting. And just to be clear, we have in our larger Medi-Cal system, Vivitrol in the oral and the long-acting is available. Okay. And it can be used. And part of the waiver, what we want to do as well is increase the education for counties and providers of how to access those benefits and how to start. Perhaps they don't use it currently in their county, how they go about that. We also have in our northern counties, for the NTPs, the highest one we have is in Butte. So we don't have any NTP facilities above that. So we're looking at multiple ways to come at this medication-assisted treatment issue, and there's lots of different things that we have in place with the waiver and outside of it, just because of not only the evidence-based practice, but the heroin epidemic and the overprescribing opioids. So we recognize that, and there even are pieces of the waiver that explain where the different medications are available, but we're not limiting it in any way. We're actually expanding. So
counties, I just want to make sure I get this right, will be able to utilize Vivitrol or oral naltrexone as a part of their treatment protocols to help these addicts help with their
And it's through our larger Medi-Cal system. They do need a treatment authorization request, a TAR approval process, so it still runs through that part of the system.
So let me ask you, you know, a TAR is, in my view, it's an impediment. It's a delay. There's no, you can't use naltrexone for really anything else except to help somebody comfortably stay away from narcotics. What is the process to negate the requirement for a TAR? I mean, I think it's such a beneficial drug that can help so many people. Why even have the obstacle put in front of them like that?
Well, I'm stepping into dangerous territory because this isn't my area to answer. I do know that this was brought up. Oh, you don't mind? Oh, good. My director's going to save me.
It's the lifeline at the end of the table. So there's several reasons why we have drugs on our contract drug list in Medi-Cal that are subject to a TAR, either if they have a potential for misuse or diversion. It also can be indicative of the fact that we may not have a rebate agreement in place with the manufacturer. So there's a couple different reasons why drugs on the Medi-Cal contract drug list have a TAR. So and I don't know specifically to those in particular whether it's the risk of abuse or diversion or if it's because we don't have a rebate.
Well, I don't believe there's any risk to aversion. You can't get high in naltrexone. It actually will, if somebody takes it that's taking a narcotic that's actively addicted to it, it's going to precipitate a withdrawal reaction. So it would not be a drug of choice for anybody that's abusing medications. I can certainly understand the financial issues And I'm going to toot my horn a little bit. There are compounding pharmacies throughout the state of California that can custom make naltrexone in any strength, and it is cheap. I mean, we're talking $30 a month or less to provide an addict with a dose that is designed for their specific protocol. So I think that there are avenues out there, and I think that sometimes TARs are impediments, there are delays. There should be no TAR for this indication. There is no diversion. I understand the financial ramifications of the Medi-Cal formulary. You do have access to compounded drugs throughout the state of California for naltrexone with a patient-specific prescription. And so I don't know where we go with this, but I would like to just throw out there for consideration to whatever agency would be responsible for negating the requirement for a TAR. I think that it stands in the way of getting people the treatment that they need.
And we can take it back and talk to our pharmacy section and then come back and follow up with either you or the committee.
And I would be happy to consult with you on that, being that that's my profession as well, and try to provide accessibility to
Great.
these very important medications that I think are very useful tools to helping people cope with their addiction and making them sobriety and in the long term, giving them
We'll
sobriety.
follow up with you. Thank you.
So as Madam Chair gets seated, I think we're moving Department of Finance. Anything on this, LAO? And I think we're going to move to our next item next several items before public comment. Thank you for your assistance on this. Moving to item 5, drug Medi-Cal provider enrollment.
Thank you, sir.
Good morning, Madam Chair and members of the subcommittee. I'm Karen Johnson, Chief Deputy Director. I'm responsible for ensuring that we certify and enroll providers into the system. So I'm just going to go through the list of questions. So please provide an overview of the process for the drug Medi-Cal certification, recertification. So with regards to the recertification efforts that were started in July of 2013, our methodology and approach was to look at it from a geographic region, and that's how we approached our phases. Each active provider was receiving a letter notifying them to basically resubmit an application as well as a disclosure statement. Those providers who did not respond were then decertified. The other thing to note is that those individuals that are active billers are continuing to be active, billing, providing services while we go through this recertification effort. And there's a chart that is in the agenda that kind of shows the progress. But once we do receive the application, our provider enrollment division conducts a review, looks at exclusionary databases, also checks with the licensing boards, makes sure everything is complete. If there's our remediation that is required, then we actually do move forward with submitting a remediation to the provider, and they have 60 days to complete that remediation. The other part is that once we receive the additional information that we need to process the application, it goes over to our medical review branch, who then performs an on-site review and then notifies and makes recommendations to our provider enrollment division, who ultimately then moves forward with the enrollment of the provider. If there are any problems with any information that comes up during on-site reviews, there's additional remediations that would take place. But there's 5 actions that need to be taken by our provider enrollment division. The first one is to approve, to deny, remediate, refer, or withdraw as a result of the provider request. So in terms of our efforts that we have undertaken to assist providers and certification, some of the things that we have done is we've established a provider call line along with an email box for inquiries. To date, we receive about 10 to 15 calls per week. We also have about 25 to 35 different emails that we receive. Our goal and objective is to respond to those emails and those calls within 1 business day. We also have posted a webinar. We have done, webinars. We have posted those webinars to our website. We also conducted stakeholder engagements. We also hold monthly calls with our county alcohol and drug administrators, and we also periodically meet with stakeholder associations. With regards to question number 3, do we have provider enrollment have timeframes to process these applications? At the current time, there are no timeframes. However, we do have pending emergency regulations, which are going to take our drug Medi-Cal providers, similar to how we treat the other providers, and have that aligned with those timeframes. So for licensed professionals, it's 90 days to process. For clinics, it's 180 days. And have we ever considered expediting applications for providers who have already certified? We certainly do leverage that information to the extent possible, and we use it across all of their applications.
And so how does that manifest in terms of kind of the time frame? Does that make it significantly shorter?
I'm going to defer to Tanya Hammond, who's our Chief of Provider Enrollment.
Thank you. It certainly does help when we can leverage information from another application so it doesn't have to be included in the remediation request. Absolutely.
So it shortens it by,
Well, it depends, because if there's other remediations, there's still an outstanding remediation,
Got it.
and we can't move forward.
okay.
But we do try to minimize the need for remediations by leveraging other information available.
Okay, thank you.
In a best-case scenario, what kind of a timeframe? In a best-case scenario?
If we had the response quick, when we send out a remediation, we give 60 days to remediate. Sometimes those remediations come in, but they're incomplete, and we continually attempt to try to remediate so we don't take a denial action, a negative action. So it's really dependent on the responsiveness and the timeliness of that response at this, so I would not be able to gauge but by leveraging, let's say, some information from another application, it may remove that item from having to be requested, but there's still other items that need to come in before we can move forward. So it's really difficult to say that it eliminates or shaves off any particular amount of time. It's really upon the provider's time.
So I'm just having trouble understanding that from an application standpoint. We have a provider that moves down the street. They've had no issues with any agencies in the state of California. It's just transferring locations. What would be the holdup?
So a new location would require verifying that the permits are in place, the fire clearances, who is the staff involved, who are the managers, controlling interest in ownership of that location, because there could have been a change. And it does require an on-site visit in order to approve that application successfully.
But you're saying that could take as long as 90 to 180 days?
That's correct, or more, if there's delays in the remediation process itself.
I think that's very disenchanting to hear. I mean, there's got to be a way to streamline the process for these good players, if you will, that we need their professional services.
Right. And that's one of the things that I was going to bring up in question number 6 with regards to a solution that we're looking at to automate and streamline the process. So we are working, it's called our PAVE system, Provider Automation and Validation Enrollment System. And we believe that it is going to streamline the information people will be able to submit online. And I believe that because the fields will need to be populated, we'll be obtaining the information that we need prior to it arriving. So I believe that the completeness of the application that is going to be coming in is going to increase, allowing our staff then to focus on a completed application, less remediation, and being able to process and enroll more providers to serve our beneficiaries.
Thank you.
So going back to question number 5, in terms of access, if we are aware of access issues and if we hear concerns, we can certainly modify and reprioritize and focus on approving those applications first. And then in terms of our PAVE system, in terms of why it was delayed, because we were hoping to stand it up last year, we have stood up one phase of the process, which is the monitoring aspect. That was stood up in February of this year. And then the portal, which some of the providers will be able to submit their application, is going to be stood up in the August-September timeframe of this year. And then we'll work to have other providers come in within, probably the latter 6 months. So I do have to say that, part of the delays is because of the amount of business rules that are associated with the application. There's probably about 35,000 business rules. There's 70 different provider types. We're looking for an enterprise-wide solution so that it will also increase our MITA maturity, our Medicaid Information Technology Architect. So what steps is provider enrollment taken to ensure that providers in counties opting into the drug Medi-Cal waiver are prioritized in our certification process? So we have allocated additional resources within that division that is going to be dedicated. Right now, we're in the process of training those resources. We've also conducted a webinar as well, and we have posted to our website, the process of how to complete an application. We're also working on establishing a call center, so when providers do have questions, they can call in, and we provide technical assistance. And I think I'll pause there and open it up for any questions.
Yes, Senator Stone.
Yeah, I want to go back to moving the location. You mentioned that you have a series of issues that you need to get checked off, fire marshal issues. I assume ADA issues are part of that equation. But isn't that really the role of local government to make sure that a facility is meeting fire marshal standards, ADA issues? Are we duplicating an effort and creating more bureaucracy and getting these facilities open? And if we do have those included, is it appropriate that they are there? I don't think that they are myself, but shouldn't we eliminate those from the application to streamline things as best as we can? I mean, otherwise, what do we need the local government involved at all?
We absolutely agree, and that's part of our provider regulations that are moving under way right now for implementation in August. We are looking to eliminate certain things, and that would be one of them. Yes.
I applaud you. Thank you.
Finance. LAO. Okay, can we continue on to number 6, provider monitoring?
Yes, so I'm going to ask Don and Marlise to come back.
Hi, good afternoon. To address the issue as far as the overview of the request, this is to mainly request these 10 positions so that we can begin to monitor the drug Medi-Cal program. The former department and up through current through the fraud that was discovered, the drug Medi-Cal program had not been adequately monitored. The recommendations that came out of the internal audits and investigation, 32 recommendations, put in place for us to put together a team so that we started to look at the drug Medi-Cal claims. So the complexity is we have a county monitoring unit currently that monitors all of the counties once a year, and they monitor the SAFTI, or the Substance Abuse Prevention and Treatment, under SAMHSA block grant and State General Fund. They historically have not monitored to the drug Medi-Cal. So this is a workforce shift that has come into this unit. Former departments only, I believe they only staffed this function with 5 staff. Currently, under my county monitoring unit, we have a staff of 8. So the shift to do the drug Medi-Cal focus has really taken resources away from our standard monitoring. And just to give you an idea, there's 670 providers that the counties are required through the contract to monitor once a year. So as the counties go out and monitor these providers, they're required to submit a report to the state. My staff, in addition to their normal monitoring duties with the county, also must review all of those 670 reports that are coming in from those counties to meet their contractual requirements. So it's a burden to the current staff. Also, the staff in the county monitoring unit had no background in the drug Medi-Cal monitoring process until the 14-15 contract. So not only are the staff going through training and getting familiarized with the drug Medi-Cal program. It's just an additional burden taking away from their already limited resources to do our standard monitoring. So the 10 positions are required so that we can put together, again, with approval from the waiver, and as drug Medi-Cal, we're still sifting through developing policies, procedures, developing manuals so that we can develop a monitoring tool and, again, get through these reports. This team would handle all of those reports coming in from the county, in addition to setting a baseline for the staff for these 10 and additional resources to come in. We're hoping later on to build an even larger drug Medi-Cal monitoring unit.
Questions? Finance? LAO.
Amber DG, Legislative Analyst Office. We are withholding recommendation on this item at this time. We have an information request out to the department with regard to vacancies in the division to help us better understand the staffing needs, and we will follow up with committee staff after we receive that additional information.
Excellent, thank you very much. Let's go ahead and open up to public comment on the general overall drug Medi-Cal overview, provider enrollment, and monitoring. You can hit